Well, Ibrutinib is certainly a major breakthrough in the treatment of CLL, both for younger and older patients. But there are some specific concerns when we think about deploying Ibrutinib as a first-line therapy based on the results of the recently reported randomized trials to the larger population. The one concern is economic. Ibrutinib shifts a treatment from infusional or oral therapies, which were typically limited time duration, towards long therapy, which is priced at an exorbitant level, over $10,000 per month. Most older patients in the United States, often covered by Medicare Part D plans, are shocked by these prices, and for them this often means approximately $3,000 co-insurance or co-payment with the first prescription. So there's a concern how this might impact access to this medication, and whether the patient will actually choose this better treatment over historical, less effective, yet significantly cheaper, at least from the point of view of out-of-pocket costs, therapies. So that's one, if you wish, socioeconomic concern. And the second one is a medical concern. Long-term Ibrutinib therapy is known to increase blood pressure in a significant proportion of patients. Most older patients already have high blood pressure or at risk of it. Additionally, clinical trials have reported non-trivial rates of atrial fibrillation, which is a significant comorbidity that often requires anticoagulation. And Ibrutinib is also known to act as a form of a mild blood thinner or antiplatelet agent, if you wish, and it may increase risk of bleeding. Additionally, there are now new reports of a potential rare ventricular fibrillation and ventricular arrhythmias that are occurring in patients, probably at a very, very low rate. And we don't understand yet the risk factors for it. But for older patients, these are all significant medical considerations. So our study was able to alleviate the socioeconomic concern, because we found that there was no association between the choice of first-line Ibrutinib therapy and receipt of what is called low-income subsidy, which eliminates co-payments for Ibrutinib for Medicare patients. And we did not really find association with this choice between any socioeconomic factor. So it does seem that medical factors are allowing patients to, or determining the choice of treatment and allowing patients to get treatment is something that doctors and their support staff is able to do. We have shown in another study, though, that vast majority of Medicare patients require assistance from co-payment foundations and charity foundations to really access expensive oral medications in hematology. The medical concern persists. We have found that a significant proportion of patients who are being prescribed first-line Ibrutinib actually have atrial fibrillation or are on anticoagulants, which actually have been exclusion criteria for clinical trials. So as these treatments dissipate into population, we can expect higher rates of toxicities, and we have seen significantly higher rates of atrial fibrillation in the Medicare population.